Thank you very much, and thank you for the kind invitation to be here with you. It's really an honor to be back in Saudi Arabia. I've been here one time before, many years ago, so it's really great to be back and to share with you some of the updates in chronic myeloid leukemia, how I see the management of CML, which continues to evolve and continues to evolve for the better. My focus today in this presentation is going to be on the guidelines and the importance of why we focus on these guidelines. And this is topical because we are right now working on the new edition of the European Leukemia Net guidelines. We're going to be meeting at the European Hematology Association meeting in a couple of weeks. Probably will be the last meeting before we start writing the manuscript. So it'll probably have some additional updates. These are my disclosures. So it is very clear to all of us that the outcome of patients with chronic myeloid leukemia has improved over the years, and you can see how the survival from the days where we used only chemotherapy to the introduction of interferon, and then with the tyrosine kinase inhibitors, it has greatly advanced that expected survival in something that we have not seen with too many other hematologic malignancies or cancers for that matter. And with that, we know that today a patient with a diagnosis of chronic myeloid leukemia, for the most part, can expect a normal life expectancy. That is that they can live as long as any other individual of the same age and the same characteristics. And they're probably not going to die of CML if we have the opportunity to give them a tyrosine kinase inhibitor, if we monitor them well, if we manage them well, and move them through these guidelines in the proper way. Now, there have been some dissents, and many times I've heard that some colleagues have said, well, we introduced second-generation tyrosine kinase inhibitors as frontline therapy, but yet that did not improve the survival of patients. Well, that's very difficult to expect when you already have a near normal life expectancy with imatinib. But I think it is important to recognize that as we have improved on the therapy and the ways to monitor our patients, we have evolved in the management of patients with chronic myeloid leukemia. First, we also need to recognize that this improvement in the overall survival that we see in very selected populations, for example, from clinical trials, from very specialized centers, has really not reached everybody. These are statistics from, on the left, from the MD Anderson Cancer Center. When I was working there, as you heard, I was there for 27 years before moving to Georgia. And on the right, this is the epidemiologic data from the United States that takes all of the population in the United States. And surely we have seen an improvement in the overall survival, but it's not nearly as good as we had seen at the MD Anderson. So there's still a lot of room for improvement. So why is it not as good in all of the patients that we have in the US? And I think that probably applies to many other parts of the world. Well, one of them, of course, is the access to drugs. There's many patients who really don't have access to drugs, so, even in the United States, and certainly in the parts of the world where the access, because of the cost and other issues, is not as good. But also because of the monitoring. The monitoring that I see happening in the community in patients that are referred to me is not optimal in all instances. And the management of patients, the opportune detection of treatment failure, the opportune change of therapy when it is indicated, we are really lagging behind on that. And that is part of the reason why many of these patients don't do as well as they could be doing. I also see that the dosing is not done appropriately in many of these patients. So you really want to optimize the dose for each patient to make sure that they get the greatest benefit. Of course, the clinical trials, in addition, have a patient selection. We select them by their eligibility criteria, and that makes them more fit than the average population with chronic myeloid leukemia. And then there's the adherence to therapy that may be faulty. So, but I think that what's very important to recognize is that the CML has evolved in many ways. The treatment has clearly evolved. Again, we started using chemotherapy when I was doing my fellowship. That's all I had. I started in Mexico. We didn't even have hydroxyurea. We only had busulfan. Now we have many tyrosine kinase inhibitors. We also have much better ways to monitor the disease, from just focusing on a blood counts to going through cytogenetics, FISH, and now a quantitative PCR, and little by little moving to a digital PCR. With that, our endpoints have evolved. We don't focus only on hematologic or even cytogenetic responses. More and more, we focus on molecular responses, and particularly on the deeper molecular responses. And the goals have changed from just controlling the symptoms and improving survival to focusing on event-free survival, and more nowadays in treatment-free remission. So when you think about a patient that's newly diagnosed with chronic myeloid leukemia and you start the treatment, you go from achieving a hematologic response, a cytogenetic response, and a molecular response, and so on. But there are situations where you're going to identify that the patient is not doing well. Certainly when there is resistance or when there is intolerance, we know that we need to change therapy. But there are other instances that more and more we are starting to recognize that represent a challenge for the patient's long-term endpoints. Suboptimal responses, or what we call warnings in the European Leukemia Net, and low-grade toxicity, which also can be very damaging for the patients in the long term. And even patients who are not achieving a deep molecular response, when the endpoint, the goal of the patient is treatment-free remission, we are starting to think, should we be changing therapy for some of these patients? So the ELN recommendations have said very clearly the goals of therapy at given times, and what constitutes then within each of these times an optimal response, which is what you see in green, and a warning, which is like an alert that we need to be aware of, and then a failure, which is a clear indication of therapy that if you recognize, you need to change immediately. For the warnings, there's a little bit of debate. In some instances, we choose to wait. But again, if your goal is to achieve deep molecular response and getting treatment-free remission, early recognition and early change is what's going to give the patient the best chance of doing that. In the US, there's the NCCN, so the National Cancer Center Network. These are the largest cancer centers in the United States. They come up with recommendations, and they're very similar to what you see with the European Leukemia Net. The big difference is that they only go into 12 months. They don't address what happens later on. But again, the emphasis is the importance of those early responses and why you need to recognize them early. You can see here, at 3 months, you already have a warning for the greater than 10% and a clear failure at 6 months if you're above 10%. And the recommendations, very similar to the European Leukemia Net, change certainly when it's a red, and in many instances when there is a yellow. Now, that is for the frontline therapy. And the European Leukemia Net says you can use the same guidelines for the second line of therapy. So meaning a patient who took, let's say, imatinib, then you give a second generation TKI, you can use the same guidelines. We continue emphasizing the early responses in the second line. But one important thing that the NCCN guidelines mention is that once a patient has had 2 prior TKIs, usually there'll be imatinib and a second-generation TKI. For second-generation TKIs, I'm talking about dasatinib, nilotinib, or bosutinib. The use of another second-generation TKI is really not recommended. You really should be focusing on either ponatinib, asciminib, or a clinical trial if that is available. So with all of these, there are different approaches to changing therapy. One is the reactive approach. That is when you change when there's clear evidence of resistance or clear evidence of intolerance. Of course, in that instance, we need to change therapy. That is very clear. Now, if that happens all of a sudden, well, that's all you can do. But if there are warnings before that, you can do a preemptive approach of changing therapy before this becomes a trial failure to try to improve the probability of the patient having a good endpoint long term. And we need to remember always that we're looking at what the patient can achieve in the long term, not just how the patient looks in that context. And that's why more and more we are starting to look at ways to improve proactively and consider even some changes in at least some patients proactively, particularly when you're focusing on treatment-free remission. So let's look at some of the data that backs all of these reasons for changing therapy and changing opportunity. When you look at all the frontline studies, and I'm focusing here on the 3 main randomized studies of imatinib versus a second-generation TKI, imatinib versus dasatinib, Dasition, imatinib versus nilotinib, an SND, or imatinib versus bosutinib, which is the before trial. As you can see, it is very consistent in all these studies, and keep in mind, these are very selected populations, and yet, by 5 years, 40% of patients, whatever they're using, imatinib or the second-generation TKI, you can see it's very, very consistent that 40% of patients have already changed therapy. So as good as we think that these treatments are, already 40% have required to change therapy. And we have one study, the NSND, that follows patients 10 years, and 50% of patients have required to change therapy. So many patients really will need to change therapy in the long term. You also remember that some years ago we established that the 3-month response then became very important. We are trying to identify these patients early on so that we can change their therapy and or do something to try to improve their long-term outcome. And in all of these studies, they showed us that patients that by 3 months have more than 10% transcripts, they do not have the same probability of a good progression-free survival. They do not have the same probability of overall survival in the long term. They're going to be okay for the next 3 or 6 months, but they're not going to be okay in the next 3 or 5, 10 years for sure. And it's very interesting when you look at the data that has been published with these 3-month response. On the left was that initial call to attention of this early molecular response from the Hammersmith, David Marine, when he was working at the Hammersmith. And on the right, you see one example with one of these second-generation TKIs, in this case, the Dasition study. And both of them show that if you have more than 10% transcripts, the overall survival is worse. But look at the difference in overall survival for these patients. Here, it's about 80%. Here, it's only about 50%. Why such a big difference? The main reason why there was this big difference is that at this time, the British authority had not authorized the payment of dasatinib or any second-generation TKI after failure for imatinib. So the change happened very late. And with that impacted the survival very significantly. Whereas not when in this setting where you could change the patients very quickly to dasatinib, the survival, yes, it's worse because these are worse patients, but it's not as poor as the survival that you see in this other study. So what can you do for these patients then? There's only been one randomized study that has looked at changing therapy versus continuing on imatinib. That's the CERN study. This is a study that we presented at ASH last year. We're sending it for publication now. So patients who at 3 months have more than 10% transcripts while on imatinib, randomized to change to dasatinib or stay on imatinib. And as you can see, the probability of achieving a major molecular response long term is better, statistically significantly better for the patients who switch to dasatinib. So if you're focusing on these deep molecular responses long term, it may have a benefit. Now we need to see more follow-up to see that those deep molecular responses really make a difference. There's not much of a difference in overall survival or progression-free survival, because the patients who didn't change at 3 months, they changed later on at 6 months or 12 months. This is a warning, not a failure. So it probably that makes a difference compared to that strategy by Marine of changing very, very late. But if you are focusing on a deep molecular response, it does make a difference to change at 3 months. And this is an analysis that we did many years ago, and which emphasizes that if you have more than 10% at 3 months, should the probability of major molecular response decreases significantly. But if you are by 6 months or by 12 months, look at how few patients are going to get a major molecular response over time. So the longer you wait, the lower the probability of a patient really achieving a deep molecular response. This is only major molecular response. Deep molecular response is even less. And the greater the risk of transformation, of progression to an accelerated or a blast phase. So again, emphasizing the importance of early recognition of this phenomenon. And here's what you can see for deep molecular responses. What I showed you in the previous slide was major molecular response. This is MR 4.5, and this is sustained MR 4.5, what you need to consider a treatment-free remission. And you see this is by 3 months. These are the patients who are more than 10% at 3 months. And the longer the time, the worse the probability of achieving ever a deep molecular response. This is by 18 months. If you're waiting all the way to 18 months, really nobody's going to achieve a deep molecular response, and even less a sustained deep molecular response. Now, what does achieving a major molecular response mean? Well, the major molecular response is important because it decreases the probability of event-free survival. So it doesn't improve the probability of survival. Again, the survival has already reached that of the general population, but decreases the risk of the patient eventually having to lose the response and requiring additional intervention. So that's what we focus more in these molecular responses. And even the deepest molecular responses. So in this study from Germany, from the CML4 study from Germany, clearly the survival is the worst for patients that have more than 1%. But the deeper the molecular response, the better the survival. Now, this is not statistically significant because the follow-up is short and the number of patients doesn't quite make it to provide significance. But you see the best curve is the less than 0.0032, and little by little it starts getting worse and worse, and it starts opening more the higher the transcripts. But more importantly, it really impacts the failure-free survival. And by failure means anything that requires a change in therapy. Of course, a transformation, a loss of major molecular response, a loss of complete cytogenetic response. The lower the transcripts, the better the probability that the patient will not have to change therapy at all ever. So that's why we focus more and more on these deep molecular responses, in addition to the benefit for treatment-free remission. Now, we also know that when a patient has failure to a tyrosine kinase inhibitor, to their first tyrosine kinase inhibitor, their survival is not as good any longer, especially if you have if you don't have too many options, or if you wait too long to use them. This is very old data. Look, it's 2007, so this is 16 years ago. But this is when we started seeing patients on imatinib who had a failure. At that time, we didn't have yet widely available the dasatinib and the nilotinib, or all these other therapies. And you can see the survival, the median survival was about 5 years, meaning it started to look like the CML of old days before we had tyrosine kinase inhibitors. Of course, if they had moved to accelerated phase or blast phase, it was even worse. But clearly, this is not the kind of survival that we want to see today, that we can see today, because we can change patients to alternative tyrosine kinase inhibitors. And even in the second line of therapy, that early molecular response matters. So these are patients on dasatinib after imatinib failure. And again, the 3-month response, greater than 10%, has a worse survival than the patients that have a good molecular response at 3 months. We tend to think that we have a very good approach for patients who have failure to imatinib, that we can switch them to a second-generation TKI, and that the outcome is very good. Well, is that good? Is that treatment really that good? Look at the data from all these 3 drugs after imatinib failure only. This is the original data that led to the approval of all these drugs in this context. As you can see, the complete cytogenetic response is only 40%, 40 to 45%. That's complete cytogenetic response. That's not molecular response. It just completes cytogenetic response, which is good, but it could be better. Nowadays, should be better. And even then, it's only 40%. Now, I'm showing the data here at 2 years because that's where we have data equivalent for all these studies. But if you look at the more recent data with 8 years, and for that one we have data with bosutinib, it has changed very little. It's gone up to 50% after 8 years. So at best, 50% of patients have achieved a complete cytogenetic response. So that tells us that, yes, that treatment is good and it's better than not having those alternative treatment options, but it's certainly there's room for improvement in this context. Also, in these patients, we demonstrated again many years ago, this is 2009, the importance of switching early. See what happens when you switch. In those days, we were focusing mostly on cytogenetic versus hematologic response. PCR was not as well established. But the patients who switched after losing their cytogenetic response, they had the best outcome. Patients who switched after they had already lost their hematologic response, their outcome was not as good. So showing that early recognition and early switch was very important in this context. And that translated into much better event-free survival if you switched with early, and a better overall survival if you switched early as well. And as you go from a second TKI to a third TKI to a fourth TKI, it is very clear that the survival of these patients starts getting worse and worse and worse, and the transformation-free survival of these patients starts getting worse. So letting the patients go through failure really has an impact. It may not be immediate, but certainly it has an impact long-term in the probability of survival and of transformation-free survival. I mentioned earlier what the NCCN says about a patient that has gone through 2 TKIs, imatinib and a second-generation TKI. And this is mostly all of the reports that have used going to the third TKI being another second-generation TKI. And as you can see, the results are not very good. The probability of complete cytogenetic response is about 20 to 30% in almost all of these studies. And molecular responses are even worse. So in my opinion, going to another second-generation TKI after already having resistance to one second-generation TKI is what I call a lateral move. Yes, you can do it, and the patient may be stable for a little while, but you're not really giving the patient the best opportunity for a good response long term. And that is reflected in a very poor survival. As you can see here, even in chronic phase, the median survival is less than 2 years. So clearly not what we want to see in these patients now that we have better treatment options. What are these treatment options? The first third-generation TKI was ponatinib. Ponatinib was introduced with the PACE study. You all know about it. And it was effective, but it gave us the arterial occlusive events. So recently we did this study looking at the optimal dose of ponatinib to try to minimize the risk of arterial occlusive events. In this study, what we saw is that the best response rate was with a 45 milligram standard dose, but reducing the dose once the patient reached 1% or less. There is more toxicity, arterial occlusive events in particular, which is the biggest concern that we have. There is more of that with 45 milligrams than with 30 milligrams. With this approach, it's not quite as high as we saw with the solid 45 milligrams that we were using in PACE, although we still need to monitor these patients carefully. One important element, and this is taken from the abstract, the full data is going to be presented at EHA later today, is that even in this context of patients who have received multiple prior therapies, early response still matters. Patients who have greater than 10% transcripts by 6 months, you can see that the probability of progression-free survival and overall survival is much lower. And I'm not going to go through the whole table, but that's the message that we can see even in this context. Now, patients who go through ponatinib and don't do well, their outcome, their probability of success is very poor. As you can see, very few patients will respond to additional therapies. This is in 2018. That's before we had asciminib, and their overall survival was very, very poor. Well, as I mentioned, now we have a new drug, which is not only a drug that also covers multiple prior therapies and T315I, but the important thing is that it has a novel mechanism of action. Yes, it's a tyrosine kinase inhibitor, but it's not an ATP competitive binding inhibitor. All of the other tyrosine kinase inhibitors bind where the ATP binds in the kinase domain. This one binds in this myristoyl pocket, which is important because, number one, it's not affected by most of the mutations that we see in patients. Number two, that myristoyl pocket is very unique to very, very few kinases in our body, which makes it much more targeted, more selective than the traditional tyrosine kinase inhibitors. You all are familiar with the data with asciminib in this phase 1 study, where we started to see very high levels of response in patients treated with asciminib after multiple prior tyrosine kinase inhibitors, and even in patients that had received ponatinib previously. And again, one important thing, the patients that had switched to asciminib when their transcript was still relatively low, but they had already shown clear failure to the prior tyrosine kinase inhibitors, they do better. Again, the emphasis, early switch, makes a difference. And that led to a randomized study of asciminib versus bosutinib in this context of at least 2 prior tyrosine kinase inhibitors. It demonstrated a significant benefit for asciminib, with almost more than doubling the probability of major molecular response at 96 weeks compared to bosutinib. Now, we did see a few arterial-occlusive events, but keep in mind that the exposure was much longer for asciminib. So you have to adjust that by the exposure. When you do that, that difference shrinks a little bit more, but much less than if you don't do the adjustment. Always have to look at the exposure-adjusted risk of these events. It is also, as I mentioned, very effective in T315I patients. Look at these major molecular response in almost half of the patients, and even patients who have received prior ponatinib have a very respectable almost 30% response to asciminib. So a very active drug, very effective in this context, and we are starting to look at different indications for ponatinib, for asciminib. So this is, in summary, how we sequence therapies. Of course, when in the first-line therapy, this is all of the drugs that are approved in the U.S., imatinib, generic imatinib, nilotinib, dasatinib, and bosutinib. And then for second line, we have all the other drugs. Now, I do think that for patients that have resistance to a second-generation TKI that was used as frontline, to me, what I do is I give them ponatinib or asciminib. I don't do another second-generation TKI. And then, of course, for third-generation TKI, the drugs of choice should be these drugs, ponatinib or asciminib, not another second-generation TKI. So now, is it that simple? Well, for imatinib resistance, yes, we can switch to a second-generation TKI, but I already emphasized that the results are not great. So I prefer to use a third-generation TKI. We are doing studies with asciminib in this context because I think it can give us much better than what we are seeing with the traditional TKIs. Again, if the patients have received one second-generation TKI as frontline, I do think that the third-generation TKI is the treatment of choice. For suboptimal, right now what we do is monitor closely. I think that early switch, and we'll see the long-term results of dasatinib, the DASCERN study, but it already shows some early benefits. So in summary, when do I change therapy? Certainly when there's a clear failure by the European Leukemia Net definitions, when there's loss of complete cytogenetic response, when there is intolerance, those patients you really need to change therapy. And even in many patients with suboptimal response, especially if it is a patient that's interested in treatment discontinuation in the long term. So my final words, one, just keep in mind that just being PCR positive, that's not a failure. That is not a scenario where I change therapy. But in 3 months, I am doing it. I do have clinical trials. And outside of a clinical trial, in those patients that I'm focusing on treatment-free remission, you need to know that you have something better. Again, not from one second generation to another second generation. You need to go to the drugs that are more effective in that context. There are some adverse events that we can manage, like diarrhea. Don't keep your best treatment options for later just in case. In cancer, you use your best drugs as quickly as it's indicated so that you can give the patient the best outcome. I don't leave anything for later on. Certainly, transplant is still a valid option for these patients. So, in conclusion, I'm going to close with these words of Winston Churchill, who said, "There's nothing wrong with change if it is in the right direction." So we just need to make sure that we make the change in the right direction for these patients. And I want to just remind you of our CML conference that's going to be this year in Mandaloo in October 6th to 8th. It's a beautiful place, a great conference, so hopefully we'll see many of you in that conference. So with that, I conclude. I thank you for your attention, and I'm happy to answer any questions.